Hello, welcome everyone. Welcome to the APHA Addressing the COVID-19 Crisis, an open forum webinar series for pharmacy. I'd like to introduce myself. My name is Sandra Leal, and I am the Executive Vice President at Tabula Rasa Healthcare, and I'm also the President of the American Pharmacists Association, and I'll be the host and moderator for today's webinar. We have a great topic today. We will be discussing the considerations for at-home vaccinations and the new Medicare opportunities to be reimbursed for administering COVID-19 vaccinations to people in their homes. There's been a lot of changes with reimbursement, and being able to provide vaccines at home is a wonderful topic. We're excited to have a couple of featured speakers here, and we're very, very happy that they will be sharing their personal experience. Our first speaker is Saad Dino. He is an owner of four family independent pharmacies in the suburbs of Boston, Massachusetts, with his brother, who is also a pharmacist. He is currently the president-elect of the Massachusetts Pharmacy Association and serves on many committees such as the Emerson Hospital Care Transition Collaborative Committee and the Cardinal Distribution East Advisory Board. Saad is a resident of numerous awards, including the Margaret Baum Outstanding Medical Professional Award for his work serving the needs of the autism community, the Massachusetts Innovative Pharmacist of the Year Award, and the 2014 Dr. M. George Weber Compounding Pharmacist of the Year Award. So really, really happy to have Saad joining us today to share his experience. We also have Rebecca Brown, who is currently working as a pharmacist at Amelia Pharmacy and Cumberland Pharmacy, both independent pharmacies located in rural Virginia. She received her BS degree in biology from Virginia Tech in 2002 and her Doctor of Pharmacy degree from the Virginia Commonwealth University in 2006. Her passions have always been to reach those in the areas throughout her pharmacy practice, and she reports that she's truly been the highlight of her career to administer life-saving vaccines, as well as implementing an at-home vaccination program to reach the most vulnerable patients in her community. So really, again, very excited to have both of you share your experiences. We also have our internal subject matter experts for questions. Here joining us today are Dan Slaw, and he's a Senior Vice President of Education and Business Development at APHA, and he brings 10 years of experience at NIH as an oncology infectious disease specialist. He also brings the latest breaking news as things are changing with vaccines. So really happy to have Dan on today. Today we also have with us Michael Baxter, who is the Senior Director of Regulatory Affairs at APHA. He is a primary liaison to CMS, and he will be providing an overview of new regulations impacting payment for at-home vaccination. So we're really happy to have you, Michael, share the new information that's breaking. So really happy to have this great group on the call today. So a little bit about the format for today's webinar. We've gone over the introductions, but what we will do next is introduce and have Saad and Rebecca for discussions. That'll happen for about 25 minutes, and then we will go into the open forum discussion to share your ideas and your questions or concerns as you're hearing the conversation. So please make sure you're adding those questions to the toolbar, and we will go through and get through as many of those questions as we can. You will also see a handout of the slides with the links to the resources during today's presentation. So feel free to download that so that you have that information as you move forward through this conversation. So thank you again for joining us. What we'll have now is we'll have Saad and Rebecca join us. We'll have them turn on their camera and we will get started. Well, hello, Saad and Rebecca. Thank you so much for joining us today, and thank you for sharing your experiences. You're doing phenomenal work out there. You're the example of, you know, what we talk about, like really leaning into this pandemic and helping to overcome such an incredible situation. So I'm going to start with you, Saad. If you can share a little bit about your practice and the work that you've been doing to roll out this COVID-19 vaccine in-home program. I know there's so much interest in doing that, especially as the, you know, as people have stopped, you know, coming in and the volumes to the sites. It's incredible that you're now actually able to go into people's homes and provide vaccines. So if you can share a little bit about that, I'm excited that you have some pictures to share.
Thank you so much. Thank you so much for having me, Sandra. I appreciate it, and thanks to APHA for inviting me to be present on this presentation today with Rebecca. Um, so my name is Saad Dino. I'm a owner, as Sandra stated, of 4 independent pharmacies. Basically, we're in Massachusetts, and our vaccine program started roughly in beginning of February. In the state of Massachusetts, we were excluded from doing an in-store vaccine program at the beginning due to supply and such. But my brother was able to develop a relationship with the state where we began vaccinating individuals that are in corrugated facilities, group homes, and those aspects. And that's actually where we started doing what we consider in-home, in-home-bound vaccinations, because a lot of those individuals were in one central location, typically, and 8 to 12 individuals living in a residence where we went to the home, we went to their residence and vaccinated those individuals. At the same time, we're also, this picture here is a commission for the Blind Association, where they had roughly 500 individuals that were brought to the facility in a central location, and we were able to vaccinate all those individuals in separate weeks. The process was incredible. It was rewarding. Sometimes you get teary eyes talking to these individuals. It was just incredible. Going back to the group home aspects, one very touching individual that I speak about all the time, happens to be part of a 12 patient resident, and this individual was bedbound. He can't get out. He's quadriplegic and such, but could speak, verbalize, no problem. And I went to his room because he couldn't even come downstairs. So I went upstairs to his room to vaccinate him. And I could, as I finished vaccinating with his first dose, tears came down his eyes, and just said, "This is absolutely incredible. I can't believe I'm getting vaccinated. I thought I would never be able to get vaccinated because I'm in my bed here. I can never get out." And which made me start tearing up a little bit, because these are the touching stories that I think everybody on the phone call that has been vaccinating has many of those stories to tell. And and then we built that up slowly, building a relationship with the state, and then we started doing low-income housing, till finally in April it opened up an in-store vaccination program, or maybe late April, and that's how we began. The relationships that today we're talking about the inbound, the homebound patients. What worked for us was it's all about relationships. Relationships. We were able to build a relationship with a vaccine coordinator in town, that I text as we were vaccinating, having clinics, we're texting back and forth of extra doses that we may have. She's an EMT, she's a deputy fire chief as well in town, and has been an absolute supporter of us as we were supporter of her, trying to vaccinate as many individuals as possible that were qualified at that time. The Council on Aging, was a tremendous asset. The local Board of Health, again, we're communicating constantly on a daily basis, trying to figure out how, who needs vaccines, who needs to go to the with me to go to a home, so I have a backup if need be. And then lately, it's been the local internists and local hospitals that don't have vaccines anymore. They stopped doing the vaccine program. Those are the individuals that we get calls from them asking us to go and do a home visit because a patient can't leave their home to get vaccinated. So, it's been absolutely rewarding, absolutely amazing. So thank you for allowing me to share.
No, that's amazing. I mean, I appreciate you sharing the patient story. You were making me tear up here too, just because to hear those words that somebody thought that they were never going to have access, and that you actually facilitated that is why we do the work that we do. So I appreciate you sharing that experience. And then to the point you're making about relationships, that's so key. A lot of these relationships, have started way previous to the pandemic, and it's incredible how they've come full circle now, and how we've leveraged these relationships to make these opportunities happen. So thank you so much, Saad, for sharing that. I'm going to go over to you, Rebecca, and I know there's a video that we wanted to share because you were part of this APHA vaccine confidence project. So I'm excited to share this video if people haven't had the opportunity to see these. This is one of a series of videos, and we're going to share your practice, and then I'll have you comment, Rebecca, about your experience.
We have people who are homebound. We have people who can't get out, who don't want to get out. You know, that might be something, a reason why they don't want to get vaccinated. We say, no problem. We'll come to your house and do it. It's important to meet people where they are. These are the people that need to be reached too. They don't have the resources to be able to even pay someone to come in, watch their loved one who's homebound, and be able to come up to the pharmacy. So we do these home visits in order to cover the whole household. We're a small-knit community. We know the people, especially Rhonda has been instrumental in knowing who is homebound, who needs the extra assistance, and we just make it happen. This is one of patients. She is a 30-year-old stroke victim. She had a stroke after she delivered her baby. So she is homebound as well as her caretakers. These are the people that are sometimes the hardest to reach, but the important thing that Rhonda and I want to do is be available. Be like, hey, there's no barrier to you getting this. All you got to do is just tell us what day and we'll make it happen. In our rural communities, people don't have cell phones, they don't have computers. A lot of it is word of mouth, cold calling folks and being like, hey, we know that you have a family member that's homebound, how can we help? And they'll say, hey, we didn't even know you would do that. I say, absolutely.
The family that we're visiting next is a husband and wife. He's actually suffering from dementia. They haven't been out in a year, nowhere. Their kids come and do their grocery shopping and everything for them. So once they get their second shot, this is going to allow them to actually see more family members and actually get out and about a little bit more.
Yeah. You can just sign it and date it down there. How about that? And I'll fill it out.
Okay.
Yeah.
I got it.
You good.
I got it.
You good. No big thing. All right.
Yeah.
You do.
That's what I always say. You never know.
Yeah. So now you can be able to go to the grocery store.
I haven't been to the grocery store in over a year. I'll forget how to shop now.
All right. You too. Take care, Bo.
All right, Bo.
Enjoy that grocery shopping.
Thanks for the oranges.
Vaccine day really is the best day. Just us being able to go out and do this, it's the highlight of both of our careers, and being able to help our community. Every shot counts. If they can't come to us, then we're going to take it on the road to them.
Wow, that's incredible. What a amazing work that you're doing. I am so glad we had the opportunity to see that video and to share your experience, Rebecca. I wanted to see, what else you wanted to add from your practice or comment on the video.
I mean, it really takes a village, from people in the community letting us know who needs the vaccine, from the people at our pharmacy who are behind the scenes doing all the billing, all the reporting. But we basically just saw a need in our community and didn't question didn't think a lot about, how are we going to get reimbursed for this? We started doing our home program long before Medicare reimbursed. And I said, we're going to use our own gas, we're going to use our own time. And it has been amazing. We are in a rural community where, especially our Cumberland store, is the only point of healthcare in that county. We do not have a doctor. So for us to be able to be the point people to get these vaccines out, get information out, we are critical in our community. Rhonda and I both hit the ground running. She is a local pastor in our community. And she was able to identify people who needed us. And so we just hit the ground running.
Well, I love the point you made about how you just stepped in regardless of reimbursement and all that. Sometimes that's what we have to do because we know it's the right thing to do. And you hope that things follow. And thank goodness that things have started to follow a little bit with the recognition and the sustainability, so we can increase that impact even more, because that definitely helps. But thank you so much for sharing your experience. A couple of the questions that we have next are, how do you identify? I think you both mentioned a little bit about how you're identifying candidates for vaccination, but can you tell us a little bit more about that? And I'll start again with you, Saad. Any, especially now as you've opened both practices, right? The practice in your pharmacy to give vaccines there, but then, how do you qualify somebody to continue the access aside from what you've already shared?
Sure. And I just want to, Rebecca, that was an incredible video. I'm so proud of what you do. It's incredible. And I know we have the same motto. You can't come to us, we'll come to you. That's what we use to get to homebound patients. We basically, like I stated, I think the number one resource has been physicians, besides our staff, identifying those individuals that either are suffering from dementia or otherwise, as in one of Rebecca's patients. Those we call their doctors, discuss it with them first, and then discuss it with the spouse and see if we can make a visit. We've done several of those. But the number one resource right now, as people in Massachusetts, we're above 60% vaccination right now, is physicians, dialysis centers where individuals can't really, go anywhere to get vaccinated. They don't want us to go to the dialysis center for vaccination because of many aspects of the COVID. But what we've offered is let us know that, we'll go to their house and we'll make it happen. The EMT coordinator that I spoke to earlier, the deputy fire chief, she's hand in hand with us. Whatever time, whenever, she'll come with us as a backup. Because if we have 3-4 individuals, we'll go, we'll vaccinate somebody, and then she'll wait and she'll be our monitor for 15 minutes or a half hour, whatever is necessary, and then vice versa. We've attended some of her clinics, and we try to coordinate when we have a clinic at our store, and those are the extra doses that we may have. Then we coordinate it with those individuals to go, after the clinic is done, and vaccinate those individuals. So, the resources I identified earlier have all sent us inbound home patients. And like I said, it started way before this Medicare reimbursement aspect, began. And reimbursement, I don't think came to our mind when we did this. It was just the right thing to do to vaccinate our communities and do what's right and get that vaccines in people's arms.
Oh, thank you. And gosh, Rebecca, you mentioned that you're like one of the only providers in that area. So that's incredible to me, because I know that there's so many counties that don't have a pharmacy anymore or a pharmacist, right? So I'm so happy that you're there. Could you talk a little bit about the same question, candidates for vaccination, but even just some of the logistics in doing the vaccines at home? I saw in the video, you're carrying your own packaging, but just some of the things that you're dealing with as it relates to administering the vaccine, observation times. Do you stay there in the home and watch people for the time that's required? Just some of those logistical kinds of things.
Yeah, so, I have my Virginia Tech bag that I have with all of my supplies in it. Go Hokies. But we also have a cooler. It's one of those ApoCool coolers that can be a freezer or a refrigerator. They are amazing. It has a home plug up and a car plug up, so it's easy to take it on the road with us. And yes, we do stay. Typically, Ron and I will go out as a team, and we stay for 15 minutes after we give the vaccination and just sit and talk. We're usually offered a snack or something. Again, small community. We know these people. We're related to most of these people. But one of the things for at-home vaccinations, I'm not really picky. If someone calls and just says, I'm working this job, you guys are closed. Can you come at 8 a.m.? Can you come at 6:30? Every shot counts, and if I've got someone who is willing to get a vaccine, I will travel to them.
That's great. What's the longest distance that you've traveled, just out of curiosity? Because that's incredible. What's your range there?
Let's see, the longest one is probably 40 minutes.
Oh, wow.
Yeah.
That's incredible. Huge commitment. I mean, I want to give you all a round of applause for everything that you're doing. It's phenomenal. How about you, Sad? Oh, I'm sorry. Go ahead.
Oh, no, I was going to say, and the other thing is, we had church leaders reach out to us and say, we've got people who are hesitant in the church. I think that we could get more vaccinations done if you could set up a clinic at our church after service. Done.
So you grab a lot of people that way, especially if you have that endorsement of the trusted community leader. So that's absolutely great.
And I'll second that, Rebecca, with the sense that there's not too far from our Acton location, which is where I am today, which is roughly 45 minutes away from Boston. There's a community supper that every Wednesday, and I contacted the director and I said, listen, why don't I'm sure there's some individuals there that may not have access to a computer, may not have access to sign up for a vaccine clinic. Why don't we set something up? So we coordinated with we didn't want to do it right at the community supper. What we did up the street, which is about 100 yards away, is a synagogue. And we were able to coordinate with the synagogue and the rabbi and the community. We have a few individuals, they call themselves the vaccine fairies, which help individuals make appointments for vaccines. What a group, amazing group to work with. And we were able to vaccinate many individuals at that clinic. And we did it, we did it on a Wednesday from 4:30 to 6:30, right after, they picked up the food, and, they picked up the food, came to us, vaccinated, waiting 15 minutes, and went on their way. And we did the Johnson & Johnson with that one, because that's what they wanted to do because of nervousness about not them coming back for their second doses. But that has worked out amazing as well. And again, going back to my comment that Sandra also, it's all about relationships, building a trust in the community. We somewhat became the resource center for these vaccines for many individuals. And the furthest I traveled, because we have 4 locations, we went 13 miles to give a vaccine to a homebound patient that nobody else was able to provide. There was no independent pharmacies in that area. We got a call from a physician that has had this patient for many years, and we were able to go and do it.
And just thank you so much for sharing. That's incredible. So you've got quite a bit of a reach there also. Any tips as far as like any of the logistics for you as you're doing the at-home vaccines? Rebecca was sharing her cooler and the system that she used, but anything as it relates to vaccine wastage, has that been a problem for you all, or have you been able to use what you have and address some of those issues? And you mentioned Johnson & Johnson as one of the vaccines for a particular group, but anything that you've seen as it relates to those types of
It's like I said, we tried to coordinate around our clinic clinic days. Several weeks ago was every day, but lately we're just trying to keep not wasting as much. So that has worked out really well, because these individuals are home, and like Rebecca said, as long as you go within the times that they're home. But if they're homebound, they're homebound. But if they're working and they need a vaccine, we work around their time. But we were able to kind of coordinate, again, with all these individuals, that I stated earlier, with the many professionals that we were able to work with, and minimize wastage, because we didn't want to carry all these doses around if we didn't have to. So we were able to successfully, I could say successfully, not waste one dose when we were doing that program initially.
Oh, great. Thank
And
you
we
so
had
much.
the same cooler as Rebecca, and and the styrofoam cooler if it was one dose, and that we pre-drawn and get it done within half hour or whatever. So
Very good. Well, thank you. So I wanted to introduce, I know Mike is on the call here, Mike Baxter, because he was going to do an overview over CMS payments. And I know you both started this program just because you're just good people. But I know APHA has been working really hard to try to get that reimbursement, recognition, sustainability to make sure these programs continue to be available to patients. So Mike, can you just give us a little bit of an update on the CMS and new payment parameters and the work that you've all been doing to support this?
Sure. Well, thank you, Sandra, and thanks, Rebecca and Saad. I think it's very, very interesting. This is really about bringing the vaccine to beneficiaries, and our members really asked for this. So we went to CMS and brought this to them, and really they were looking at a couple ways of doing it, maybe doing mileage, et cetera, but they thought just a flat $35 payment might be better to do it that way. So you can see here some additional information from CMS has been provided on this slide. This is on the COVID-19 vaccine at home administration rates. Medicare is going to pay that additional $35 per dose. We have heard from some sources it may be $35.50. So if you get your hopes up, maybe you'll see an additional 50 cents here and there. It is geographically adjusted as well too. And that's beginning from June 8th on. We have some helpful charts on the side. They're put together from Meg Freiter from our practice staff to break it down. So for a single dose vaccine, so if you're talking about that Janssen or Johnson & Johnson vaccine, the administration rate is going to be your $40, and then you get that $35 in-home administration fee, so it's a total of $75. Below that for the multiple doses, so if you're looking at the Pfizer vaccine or other vaccines as well, you can see that the Moderna, it's the first dose, you get the 40, the 35, so 75, but you're going to come back again, so your total there is going to be $150. You can see on the left-hand side to those two links, if you click on that first link, you'll actually see the listing of the codes to be used for the vaccine administration for the different products. And actually, midway through the page there, and I'm actually going to try to send this in the chat. This is more a direct link to those codes. So that's the first code you're going to use for the product and the vaccine administration. Now remember, the product is free for the patient, so they don't pay anything. There's no co-pays. The vaccine itself is being paid for by the government. So if you're talking about billing the administration, you'd use this code first. And then that second chart at the bottom, you can see the second link there, the CMS summary resource. If you click on that page, it'll come up, and actually for the government, this is actually fairly clear. It's very rare that this happens, but it's fairly clear and easy to understand. And it'll show you, if you scroll down to the bottom of the page there, you're going to see in light blue a section called Billing for the Additional Payment for Administering the Vaccine in the Patient's Home. And you'll see information on coding and billing, and also if you do roster billing as well too. So you have to submit 2 roster bills there. So you'll have that first code for the product and dose-specific vaccine administration, and the second one will be that HCPCS code for that additional $35. Can we go to the next slide? So this is part of the infographic that I just went over, the locations that are actually considered. And I find this very helpful as well, because it points out a couple of things and a few restrictions that are there as well. You can see you can do this extra administration fee is available for a private residence, so visiting a private residence or a home. Temporary lodgings, so dealing with the homeless population, was brought up a lot in our conversations with CMS, so you can do that as well. An apartment or apartment complex or an assisted living facility. So this assisted living facility is not a skilled nursing facility, but an assisted living facility there. And a key factor to point out there too is if you can see down through the middle of the chart, a communal space of a multi-unit living arrangement will not give you this $35 additional fee. However, if you set up there and you go to every individual unit, so in an apartment building, you can bill for that. So if you're based somewhere in kind of an open area, and that's kind of how clinics have been done in the past, you can have your materials there, but you have to go to each individual unit to be able to bill that individual additional $35 fee. So I did want to point that out. Next slide. So, and we also got this question a lot too as well for Medicare vaccine administration. Sometimes when you're going to a home, it's a couple, it's people living together, it's spouses, domestic partners, et cetera. So when you go to one household that has 2 patients in the single home, you cannot bill for another Medicare service. So if you're providing another Medicare service to them, you can't bill that same service on the same day. But if there are 2 people there, how does the billing work? Well, you're only going to get a vaccine administration fee for 1 person. So if there's 2 people in that house, you can bill for twice the vaccine administration, so that $40 twice, but you only get that $35 fee once. So if you're doing the multi-vaccine, you can see there, we broke it down in the chart, that's going to be $115 total per visit, even if there's 2 people there. So if there's 2 people living in one single residence, the total you're going to get there is $230. And again, that's adjusted by geography, so it could vary by that. You're probably going to give a lot of this back to your billing folks, but if not, and you want to get interested in billing, click on these links and you can see how it breaks down, or you can look at them afterwards and see how it's going at your practice. Next slide. So a couple key points just to leave you with, you do have to put the purpose of the visit, why you're there, why you brought it for in-home vaccine administration. It's very broad though, so you just make sure that you notate that. where you're doing your billing. And to follow up as well too, again, remember, you got to use that new HCPCS code, the new HCPCS code, which is MO201. That's for the $35 fee, and the product and dose specific code. So that's the code for whatever product you're using for vaccine administration. So those two codes need to be present for you to get that additional vaccine administration fee for in-home vaccination. And also document the patient's clinical status as well. Next slide. And I'm going to turn it back over to Sandra now for more discussion with Assad and Rebecca.
Thank you so much, Michael. That's incredible information, and so glad to have the tables that make it a little bit more clear. And I just want to remind the audience, we do have those slides in the handout that you could download, and some of those links are live, so you can go and follow the details that Michael described. And please, if you have questions, also engage so that you can talk to your colleagues about what's working and what's not. And I was going to follow up with both of you, Assad and Rebecca. How are these working out? Have you had any success yet with these codes? I know sometimes it takes a little bit of time for them to kick in, but any luck with reimbursement, you know, for either of you? And maybe I'll start with you, Rebecca, this time, and then I'll go to you, Saad.
We are in the process of figuring out how to get billing, you know, done with this. Lee, who is my partner at the store, does all the billing. And we just started, you know, last week, kind of wrapping our heads around doing that. But she has gotten some good, she's gotten one good reimbursement back. So I think she's got that figured out on her end for sure.
The first one is the hardest one. Hopefully it gets easier after that. Great. How about you, Saad? What's your experience been so far?
Same with Rebecca. You know, we have Liberty software, and we utilize an external billing service. We were able to coordinate with them the codes that we need to make it happen, and we were able to bill. So far, the Medicare claims have gone through, and obviously they go through, but we'll await payments and see what the status of those are. We were able to bill one commercial last week, and they did pay us $35 as well.
Great. Are these, and I don't know, maybe Michael can answer, are they able to be applied retroactively for the vaccines that you have given in the past, or does it start with this guidance? Michael, I don't know if you can respond to that.
Sure, yeah, it's a great question. Unfortunately, no, it's not retroactive, so it's only from the date that the new guidance came out, so from, I believe it's June 8th going forward. But they do want to hear from us, and we have a direct line to CMS. So, you know, they want to hear from us. So if you have problems or issues, you know, have your billing people contact us, or you can contact us through them. Let us know. We'll pass that straight through to them. We're probably going to have a meeting coming up with the new CMS administrator, Chiquita Brooks LaShore, pretty soon. This is stuff they want to hear, so they want to make sure that they meet the president's goal of vaccinating our population. Maybe not by July 4th, maybe a little after. But please, you know, submit us any barriers you've received or anything that good, anything that worked well. You know, they want to hear that too as well.
Great, thank you. All right, so I wanted to ask you just a few more questions before we go into the questions from the audience here, but can you tell me a little bit more about the most impactful home visit that you've made so far? And I know, Saad, you just gave a tremendous example for the patient, but anything else that you want to share, or any tips for pharmacists that are out there that are thinking about getting this started? Any lessons learned that are key that you wish you would have known before you started?
I'm maybe a little different than Rebecca, because I'm not I mean, yeah, we're outside Boston, but we're not in a rural area and such. So, you know, we, as I tell my staff, you know, we go into people's homes, and let's act, you know, professionally, and, you know, let's stay at the door till they invite us in. Wear your mask, gloves, be prepared to, you know, to show that, you know, we care about them as much as we want them to care about us in the sense of a transmission, you know, and such. Again, you know, the most touching, I told you the most touching aspect already. Last 2 Saturdays ago, I got a call from a local internist who has a patient on dialysis. You know, I just had heart surgery, was somewhat, I guess, anti-vaccinator. She goes, I finally, I think, convinced him, but can you call him? I had a conversation with him on the phone. I said, listen, I'm going to have a clinic. It's going to be done at 2. I'll be at your house at 2:30. We'll get you vaccinated. And then, you know, I'll come back again and do it again, and second dose. He says, you know, let me think about it. He calls me 20 minutes later and says, you know, I think I'm ready because, I can't go into the hospitals these days with, everybody's asking me whether I got vaccinated. I'm sick and tired of getting, that question. And I said, you know what? I'll be with you in about half hour. Get ready. And, we were able to get him vaccinated. I'm going in a week to give him a second dose. And he called the doctor and said, he can't believe that a pharmacist, he thought I was a nurse or, or other medical profession, but he couldn't believe a pharmacist came to his house to administer a dose and stay there with him for 15 minutes. And we chatted about Red Sox and all the, about many different aspects of what he's going through. And, and next thing I know, he's transferring his prescriptions to us to deliver because we deliver, and, the place he goes to right now doesn't deliver. And, it's not about gaining patients that way. That's not what I'm trying to say, is that I built that 15 minutes of spending at his house or half hour, whatever it was. We built a bond, a relationship, because he knows I'm going to have to go see him again to administer his second dose. And, the doctor called me and says she can't believe that we as a pharmacy here, a small independent pharmacy, would do that, for such patients. So, that's another story that was very rewarding. One of my staff and a pharmacist, a technician and pharmacist went to a nursing home, a new admitted patient to a nursing home, and, severe dementia as well. And we were able to vaccinate him as well because, we were able to do that, provide a service that others around me, and I'm sure around Rebecca, were not able to provide. So, I think there's a question that we'll get to in the chat, but again, relationships.
Yeah, absolutely. Wow, that's incredible. I can see how somebody could trust you and want to become your patient if you're coming to their home. That's it doesn't, it's so uncommon now these days to have that experience. So that's definitely building relationships, and what a wonderful story. So thank you for sharing that. How about you, Rebecca? Any tips, any pearls, anything you've learned that you wish you would have known before starting this process?
Don't say no. Just do it.
Just do it.
I think that for a long time, we as pharmacists have been waiting for the opportunity to show our value. And sometimes we have to wait a little bit, for things like reimbursement for home visits. But if we are instrumental in our communities. And I think that this has highlighted the opportunity that we have to not only provide COVID vaccinations, but looking at future home visits for flu vaccinations, shingles, pneumonia. These folks, some of these folks don't have access, or they can't get to a place that has access. So it's really important that, again, we're just meeting them where they are. And one of my favorite stories, or one of my favorite patients that we went to was, she's young. She's my age, a stroke victim. Her mother takes care of her, and her mother also takes care of the grandmother with dementia, and she cannot physically load them up together to get them to the pharmacy. And she was so grateful to us for coming out there and doing that for them. And, again, building relationships, like Saad said, they're now patients of ours at the pharmacy, and she's already asked me if I could come out and do flu vaccines for them in the fall. And you just say yes.
Well, what you're both describing is the best thing, which is word of mouth, right? And good PR, and not just with patients, but with providers that you're working with that will now forever call upon you just because they know that you did such a great thing. So I think that's the best testament to the work that you're doing. So hopefully it's just planting the seed for so much future opportunities. And like you said, flu vaccines, all the things that are still coming down the road that are still going to be there. So what we'll do next is start reading some of these comments, and I'm going to go ahead and give the ground rules for the open forum discussion. So definitely any thoughts or questions that you've had as you've been hearing Saad and Rebecca, please feel free to type it into the question box. And just again, a reminder that we have the handout for you there. But I do want to read a couple of the comments that have come in so far. And the first one is from Leonard Edlow. It's not a question, but a comment. He says home visits should be embraced more by pharmacists. And he said he did home visits for MTMs. and you learn so much about the patient and improve patient care. And I'm sure the experience of walking into somebody's home and seeing how they're living and what their situation is just such a rewarding thing that you can really have more opportunity to understand the patient and what they're doing. So I appreciate that comment so much, because it definitely gives you a different set of eyes for what's going on. Any thoughts about that comment? Did you do, like, I know you were waiting there 15 minutes. I have another comment here from Dr. Soto in Puerto Rico, and she's talking about, just the opportunity to sit with them 15 minutes, any opportunities to talk to them about other things like medication reviews or anything like that as you're waiting. Has that come up as you've both been out there in the field?
So, we were, as Elena alluded to, we do MTMs, but we also do compliance packaging system. So one of our pharmacists will always, go and make a home visit to introduce the system to the patient, and go over it. And that gives us a chance to, see what's on the table from a bottles perspective, go over all the medications, open a channel of trust. So that way the patient knows we're looking out for their best interest. We're going to be managing your prescriptions from A to Z. You don't have to worry about refills and all that stuff. And, we're in constant communication with their physicians to ensure that they have the most up-to-date medication. So that we're already doing that. And, so doing this vaccine aspect has opened other doors for us as well. And like I said, with the patient that was, on dialysis, as somebody said that, I'm sure you'll get to the message, but, it's just trust, right? The guy, if we didn't show up at his door, he may have never gotten vaccinated. And, and I think that's the most important aspect, is that the doctor trusted us enough to call upon us to go and do our best to get this patient vaccinated. And then the other story I had is that we had a patient that has severe allergies. She was freaking out about not getting vaccinated. The doctor convinced her that, if she comes to the office, and I would go to the office, to get her vaccinated there. It's not a home visit, but it's still a visit out of our pharmacy to go to a medical facility, so she feels comfortable. If God forbid something happened, there's someone there that could take care of her right away. They hooked her up to IVs and all that stuff, preparing her for the worst scenario. And we give her the vaccine, and we started chatting, and she's coming in tomorrow into the store for her second dose because she had no reaction, and felt comfortable that what was provided at the doctor's office was good enough for her, and she felt very comfortable with the vaccine. So that's another aspect that that you could do is make it a visit to the hospital or the medical facility that's necessary. If that's what the patient wants. As Rebecca said, don't say no.
Yeah, no, I love that. I love the just do it. I do want to read this comment from Kim Crawley, who's been a supporter of this webinar series, and she was a speaker last time. She just wanted to thank you both so much, for the work that you're doing, providing care to vulnerable patients out there. So I'm so happy she chimed in. She gave a great talk on monoclonal antibodies, and so I know this is speaking to her just because of the very innovative work that's happening there. And Rebecca, same question for you. Anything that you wanted to add to Saad, to Saad's comments?
Yeah, in those 15 minutes when you're waiting and you're building those relationships, I know in our rural community we have a high level of poverty. You can go into the homes and see food insecurities, utility insecurities, and then that's where we can also come in and help get them registered with WIC programs, with different programs that can make their lives better and have healthier outcomes. That's one of the big things that we're trying to work with our community right now, is that, hey, this is what we're seeing. How can we get these guys some additional help?
That's incredible. When you were both speaking, a model that we've used here, when we weren't physically going into the home, we use a telehealth model, but we were partnering and continue to partner with community health workers, promotoras de salud. And so they're the trusted health members that go into the communities. They live in the communities. And so partnering them with a pharmacist that's not there, that's not physically available, but having them be eyes and ears for us, and going into people's homes and seeing all of these things, and even like handing the phone or registering people with tablets, things like that. It's just that extension that I always call it that extra set of eyes that sometimes is so incredibly valuable. But if you haven't been able to physically drive like you have, there's very unique ways to still try to do this kind of work with some of the models that are going out there. So I just can't thank you enough for your experiences. And I only have one more question here that I wanted to bring Mike Baxter up for. It's an interesting, I see a couple more, but mostly they're around thank you for discussing your experiences, and then your thoughts on the $35 reimbursement. Any thoughts about the amount? Is that sufficient? Do you think, I'm sure it's better than nothing, but do you think it's enough to actually help you break even, or the adjustments that have been made? Any thoughts on that?
Sure. Well, the 35.
I'm sorry. I know this sounds quirky a little bit, but it's not about, honestly, it's not about the money. I mean it. And it's not, I mean, with this pandemic, yes, it's great to get a $35 extra. It's wonderful. It's awesome. I think the fact is that we just reiterating what Rebecca said, is that we finally, as pharmacists, have the opportunity to prove what we can do. And I think many of us on this call, tons of these pharmacists across the country have done absolutely a tremendous job. And we are being recognized finally that, we are healthcare providers. We are able to make a difference in our communities when it comes down to pandemic or otherwise. And I think that's what the most rewarding thing for us as professionals, as a pharmacy profession, is that, okay, great, I'm glad we're getting the $35 reimbursement. That's awesome. Whether it's enough or not, I can't comment. It's enough for me. It's fine. But it's the fact that we are making a difference in our communities. We are being recognized. I think that's the biggest reward you could ask for.
Thank you. No, absolutely. And Rebecca, any additional comments?
Yeah, I agree with that. $35 is more than $0. And I think that this opens up the opportunity for us to get reimbursed for even more types of services like that. So for me, it was, like Saad said, it was never about the money, and but it's nice to be recognized for what we're doing. And I think that this is going to open up the door. If we continue to push and show our value, that we're going to get reimbursed for much more down the road.
Great. So there's one more question here. I do want to bring Mike up for this. This is a question that's kind of specific, but the question is from Warren Winston, and he's asking that about a specific case. There are 2,000 members of a Southern Arizona, I believe it's a tribe, who live across the border in Mexico, but they must be Medicare patients based on what I'm understanding here. Would they qualify for the at-home visits? It's a Southern Arizona tribe.
I mean, it's a good question. I think, obviously CMS has clarified that they're not going to, there's a lot of reporting that goes on when you give a vaccine, particularly among minority populations. They want to know a lot of geographic information, all that. But CMS has come out, you do not need to check immigration status. They don't have to give that either. So you can put down your pharmacy as the location where it happened. So there is a way to do that without getting names or checking immigration status, but they will want kind of ethnicity and all that information. So there is a way to do that. I think it'd be easier, I think, if it's in the United States. If it's outside of the United States, I think you're going to raise issues there. But if it's inside the United States, like I said, I think if you go to a tribe, I'm sure that would count. That's what you saw, for instance, tended communities for homeless populations, et cetera. So if you go to a community there, that probably could count for the additional fee. But it's a great question. So I'd like to see what happens there and see when you run into issues, report that back to APHA, and we can report that back to CMS. But I can definitely clarify that you do not have to ask for their immigration status.
Great. Thank you so much. And thank you for offering to be there, because I know you've been such an advocate for representing our needs to CMS and trying to get us that recognition. And I'm just going to finish up before we get back to you, Michael, for updates. A comment from Kim Wright, thanking both of you, Rebecca and Saad. I can't thank you enough for your experiences. And she says that, you work for her, Rebecca, and is amazed by your dedication in making sure people get vaccinated. So we are so lucky to have you. And you, Saad, and all the other pharmacists out there that are doing this incredible type of work. You make me so proud to be a pharmacist because you are everything that I always wanted to be. So appreciate for both of you joining us this morning. And thank you so much. So thank you again. And we will jump into the last 10 minutes here where we're going to have Mike give us a little bit of an update on what's going on with provider status and other updates. So thank you again, Saad and Rebecca.
Sure. Well, thank you, Sandra. And as you can see real quick, everyone, you know about our provider status legislation that's out there. We need your help now more than ever. You know, our leadership's really paid off on Capitol Hill getting the bill reintroduced this year. So as we've mentioned today on today's call, if you like providing the in-home services, you want to provide additional services, you know, this is really a way to do it, and to bill on the medical side and not on the drug side. So this would apply to medically underserved areas to provide pharmacist provided patient care service, and those are already authorized by your respective state laws. But we really need your help at the grassroots level to get your policymakers and educators involved, and also make sure your elected officials sign on as co-sponsors. It's really easy to do if you can click on the links there and fill out your information. You can send letters to your elected officials, be it in the House or the Senate, because you know it's a lot more than just dispensing pills. If we can go to the next slide. One more bill that we've introduced, you've heard about DIR fees, perhaps. These are those clawback fees. You know, it's just not business sustainable to dispense a medication for, say, $5 and then 3 to 4 months later have to pay $10 back. So, you know, dispensing medications below what it costs to acquire them doesn't make any sense to anybody. There's been legislation introduced to fix this, to move that at least to the point of sale. Also would establish pharmacy quality measures, hopefully based on outcomes. Not on things like generic dispensing, et cetera, but based on outcomes. And we think our pharmacists can beat that, you know, every day of the week for improving patient outcomes. So again, we'd urge you to click on the link there and engage in our advocacy center to support this bill as well. Next slide. Okay, great. And this is our resource slide. You know, really, as you can see, there's a number of valuable resources, really a trove of information to assist our members. We have a few here on reimbursement for administration of the COVID-19 vaccine. We went over a little bit of that today with the in-home vaccination rates. That's updated information's there. Maximizing COVID-19 vaccine dosage, which provides recommendations for vaccine withdrawal and administration techniques to maximize the number of doses obtained with each vial. And, you know, pharmacist referral for monoclonal antibody treatments, which has been updated to include the latest clinical information and reimbursement opportunities for pharmacists. And now I'm going to turn it back over to Sandra.
Thank you, Michael. Thanks for all the work that you're doing. Can't thank you and the team enough for advocating for us and for updating these resources, because they get updated as we're getting breaking information. So I did want to just share some of the education materials that have become available. We have continuing professional education that are listed here, but I wanted to alert you to one that's coming up on July 13th. We have one that is the June ACIP update, and that will take place on July 13th. So please register for that for CE. We also have access to the previous webinars that we've recorded. One is on motivational interviewing to address vaccine confidence, and then the role of health equity in vaccine hesitancy. So really, really key topics that keep coming up time and time again. So really great information on that, and some CE available for you to access those. We also have a new Pharmacy Today CE article, and that's on the pharmacist's role during the COVID-19 pandemic, and also on the pediatric vaccine catch-up during the COVID-19 pandemic. So definitely a lot of questions around the younger populations. There's been so much information in the last few days as it relates to adolescents, myocarditis, you know, those kinds of things, and we'll be having more information coming out to you as we're receiving that information. But please, you know, feel free to go to all these educational opportunities to find CE and that latest information. I mentioned earlier the importance of engage, so please continue these conversations in the COVID-19 communities. Share your experiences if you're doing this type of work that Saad and Rebecca are doing. You know, share anything that are best practice tips, anything that you've learned. Have you seen reimbursement coming to you? Things that facilitate that. That would be great. There were a couple of questions around, you know, how these rates were determined. If you have those types of questions, reach out to Michael, to the team, and we can see about, you know, getting any information or advocating to CMS with you. But then also, what reimbursement challenges are you facing? Again, share those on Engage, and we can look through those and use those as opportunities and talking points with CMS. And the last slide that I have here is around our next webinar. Our next webinar will take place on Thursday, July 8th, and this will be predominantly discussing emergence drivers in the mistrust of COVID-19. So again, a lot around the approach with conversation with building trust, especially in parents and young adults. This will be another CPE that will become available, and the registration is coming soon. So today's webinar recording will be made available as soon as we put it together. It should take a few days, and it will be located in the Open Forum webinar library where we have our other CDs located. Thank you all again for joining us this morning, and thanks again for everything that you do. And one more time, I just want to thank Saad and Rebecca for the exceptional work that they're doing, and Michael and team and staff for all the work that you're doing to keep us recognized and to keep us being able to do this type of work, especially stepping into people's homes. That's incredible. So thank you all, and stay safe, and we will see you next time.